All right, thank you for the invitation to speak. So radiation oncologist to someone like me who's a surgeon, you're both my enemy and my friend. So when the wound breaks down, I curse you because it's a radiation that I blame for the reason the wound broke down. But then you're my friend too because my margins are sterilized by you and the local occurrence goes away. So thank you for that. So today I'm going to talk to you about HIPEC surgery. It has nothing to do, I think, with radiation, but this is a up-and-coming specialty in surgical oncology. We're seeing a large growth of it in Europe and in North America and in East Asia, and I think you're going to start seeing it slowly creeping into other parts of the world. So today I'll just talk a little bit about this, give a brief overview, and I'll entertain any questions you have at the end. So what I'll do today is I'll talk about HIPEC, I'll talk about the randomized data that just came out this year, very exciting for us. I won't delve too much into my research program, but I do a lot of research on HIPEC. I have a mouse model that I just interrogate different types of drugs, and then we also try and work on a clinical trial. So here's a patient that I see often. They range in age between 30 to 60. A patient presents with abdominal distension. They get a CT scan that shows extensive omental implants, and they get a biopsy that shows a low-grade mucinous adenocarcinoma. They undergo some further workup with an EGD and colonoscopy, and both are negative. So I look at the imaging. It looks like the cancer may have come from the appendix. And the question next is now what? Should we give them chemotherapy? Should we go and just do surgery? Or should we consider HIPEC surgery? So this is what it looks like in the operating room. That's the omentum right there. It's caked in the middle. And beneath it is the small intestine here. You can see this is lifted up. In this particular patient, the entire stomach, surface of the liver, and spleen were coated with disease. This operation actually took 16 hours to do, but we took out all the cancer, but it just took a real long time. And you can see here that the appendix is a source. So if you look at I'm holding a cecum with my hand, and that thin structure coming. Is there a pointer here?
There is
one. There is not one? Oh, okay. That thin structure there is the appendix, and at the very end of the appendix is the mucin coming out. So peritoneal diseases, cancers of the peritoneum. If it's primary, it's mesothelioma. So we do have cases of mesothelioma occurring in the abdomen primarily, so just not limited to the pleural space. The more common disease that we see is actually secondary peritoneal surface malignancies. And these are cancers that come from the appendix, colon, rectum, ovary, or stomach. And from there, the cancer then spreads to the peritoneal cavity. So a word to describe this condition is called pseudomyxoma peritonei. This stands for, another word to describe this is jelly belly. I don't know if you've ever seen a patient like this, but they show up with a large amount of distension, and they have ascites, but the ascites looks like jelly. And any disease process can lead to mucinous ascites. And we see it from the appendix, all the GI organs, and the ovaries. And if you don't treat this, it's uniformly fatal. So patients will die within 6 months, typically, of this diagnosis. I'm going to just, if you have a moment, I would like to show you something really quick. This is a video. Let's see if it works. There it is. How do I get this on there? Do you know how that works?
Oh boy. Let's see. Can we maybe get out a PowerPoint and see if that works?
No, I'm sorry.
Maybe Lewis might be able to help you out.
Sorry about that.
Okay. To increase the size, you go here.
No, but the video on the screen?
So
it's not showing on the screen here.
if you want to play, maybe.
I'm sorry, I should put this in the video. Take this thing.
Minimize and they go to the
It's okay.
something should come presentation.
I'll turn it off then.
Okay.
It's okay, I'll do it.
It should come with this extension.
It's okay.
Yeah.
It's okay. At lunch today, well, after lunch, I'll show you a video on my iPhone. This is not something you see during lunch. I'm sorry about that.
If you need for the pointer, you should go here.
Oh, it's okay. All right, thank you. Oh, perfect. Thank you.
And then you remove from this.
Okay. So what is HIPEC? So HIPEC is a two-part surgical procedure. It's where part one, we go in and we remove all the macroscopic disease that we see. So there's cancer spread all over the abdomen on the peritoneal surfaces, such as the peritoneum, bowel, diaphragm, ovaries, liver, stomach, gallbladder, spleen, bladder. And then at the very end of the operation, we take heated chemotherapy. So we take heated chemotherapy to about 41 degrees Celsius, and we bathe the inside of the abdomen with this heated chemotherapy. And the goal of this heated chemotherapy is to eradicate and kill any leftover microscopic disease left behind. We put this heated chemotherapy in for 90 minutes, typically 60 to 90 minutes. And during this time, a machine is circulating this chemotherapy in the abdomen. This was pioneered by a surgeon named Dr. Sugarbaker from Washington Hospital. This is how it looks in the operating room. We basically are stripping the peritoneum where all the disease is located. And so anything that has disease on it needs to come out. And this is how it looks in the operating room. So this machine here is a perfusion machine. This is the same machine you can use for cardiac bypass surgery. It's just a machine that helps circulate the chemo. You can see the catheters are going into the abdomen here. This is actually a laparoscopic one, but these catheters go into the patient and another catheter comes out, and this chemo is in a closed circuit. So using this technique, we can treat a variety of cancers. The most common one, surprisingly, is the appendix. This is actually a cancer that loves, or at least from our standpoint, loves HIPEC. If you have a patient with metastatic appendiceal cancer, it typically is limited to the peritoneal cavity, and when you give them chemotherapy, most die within a year. If you do surgery alone, this 10-year survival rate is about 32%, and the most common cause of death for these patients is a bowel obstruction. It's a horrible way to die. So if you do HIPEC, in fact, the survival is actually quite good. It's about 70% at 10 years versus about 25% and 30% for surgery alone versus chemo, which is close to zero. And so this is actually almost a standard of care for a patient with appendiceal cancer metastasis to the peritoneum. You wouldn't do a randomized trial in this population. This is a very rare population, and with the retrospective data being this dramatic, randomized trials are not needed, and in fact, the NCCN guidelines recommend a patient be considered for HIPEC if they have appendiceal cancer with metastasis. How about ovarian cancer? So ovarian cancer is a great cancer for this type of modality, and the reason why is that the most common site of failure is the peritoneum with ovarian cancer. That's how patients with ovarian cancer die. They don't die from lung and brain mets. And historically, the GYN surgeons have tried using intraperitoneal chemotherapy. You may have heard or seen in the past, especially in the 1990s, it was very hot then. They'd put a catheter into the patient, and then over the next 5 or 6 days, they'd put chemo into the catheter to help kill any leftover cells from the surgery. And that actually showed some survival benefit, but there were some problems with that approach. Patients didn't like the catheters. They caused them problems and infections. Sometimes they called bowel obstructions. So this talk, if I gave this talk 1 year ago, this talk would have ended right about now. But in the past year, actually in the past 6 months, we have 2 randomized trials in surgery. I don't know how to appreciate this. It is so hard to get a randomized trial in surgery. It's very rare for patients to randomize surgery. But here, they randomized patients with stage 3 ovarian cancer. All patients got neoadjuvant chemo, carbopaclitaxel for 3 cycles, and then in the operating room, they got randomized. So all of them got cytoreduction. All of them had their cancer removed, but half of them got HIPEC with cisplatin. Then after surgery, they all received additional 3 cycles of chemo. 245 patients were randomized. 90% received the adjuvant therapy, so we did see a lot of patients complete the full course of treatment, and the median follow-up was 4.7 years. And this is what you see. So if you look at the median recurrence-free survival, it's only about 4 months, 10 to 14 months roughly, for the HIPEC arm being favorable. But look at the survival, the median overall survival, it's about a year. And so this has now changed a lot of how we treat ovarian cancer, and more and more of the GYN surgeons are working with us to help offer HIPEC to this population. So what about colon cancer? So colon cancer is probably the most commonly seen cancer with peritoneal disease. It affects about 15% of patients with colon cancer. And interestingly, most clinical trials, when you look at colon cancer, they don't really focus on this arm. They focus on liver and lung mets, but they don't really focus on the peritoneal ones. And when you look at the peritoneal metastasis, what's it really mean for survival? Sorry, this is a little bit hard to see, but the purple line here is survival for those with peritoneal disease. The line in the middle is liver, and the line above is lung. So if you had to have the worst type of metastasis in colon cancer is peritoneal. It has the worst survival. So when you look at the background for HIPEC with colon cancer, we have many retrospective series that have looked at this. So you can see here in these 5 series, large number of patients. The median overall survival is about 3 years roughly, maybe 3 to 4 years roughly. Back in the late 90s, early 2000s, the Dutch did a randomized trial looking at HIPEC, and they found that the survival benefit was about a year. But if you look here, that their median survival, they were using just 5-FU, they were not using FOLFOX, so this trial gets criticized quite a bit. And so we don't really use this trial to justify using HIPEC for colon cancer because the chemo was outdated. So, lucky for all of us, this trial just came out. It's published. It came out in ASCO, presented just a few weeks ago. These slides I borrowed from Dr. Temple. So it's a Protégé 7 trial. This is basically a randomized trial that looked at HIPEC. And what they did was they combined 17 French centers that looked at HIPEC surgery for colon cancer. And in this trial, they randomized patients in the operating room to either HIPEC or no HIPEC, and then they followed the patients out to see how they did. And no difference. What a bummer. This thing deflated most of us because look at those lines, they're exactly the same. And this was a bit surprising, but not so much. I'll talk to you in a second for why. But you look here, the median survival was 41 months with HIPEC and 41 months without HIPEC. But the interesting thing here you need to consider is that the control arm was surgery. It wasn't chemo. In the past, we've always compared HIPEC to chemo. But what this shows here is that surgery does have a role in peritoneal disease. Historically, when a patient had peritoneal disease, they get referred to the oncologist and just get chemo. But this actually, the control arm was a surgical arm. And so as a surgeon, I look at this and say, wow, we did a pretty good job with surgery alone at 41 months. Too bad the HIPEC didn't add anything. But compared to the other retrospective data that showed survival of about 36 months or 35 months, this is actually a home run. You look at relapse-free survival, really no difference. Maybe a month or two in the beginning, but it plateaus out as you follow the patients longer. Now this is interesting. So this is where someone like me gets a little bit more into the data. This is a forest plot. So if you look at a forest plot, you're looking at the line going down the center of the plot is a hazard ratio of 1. And the dots represent different data points, different variables, and where they may actually fall if looked at substratified. And I'll just point your attention to this area here that I circled, the PCI. So when we do these operations, we have to score the entire abdomen into 13 regions. Each region gets a score between 0 and 3. And 0 means there's no cancer there, 3 means a lot of cancer there. So the maximum score you can have is a 39. Most of us, when we offer HIPEC for colon cancer, offer it for a PCI of about 20, so about half. Half is what we offer here. If you look here at this forest plot, a PCI between 11 and 15 was a sweet spot. It was actually the population that did really, really well. The ones that had more than 15 didn't do well, and the ones that had less than 10 did not do well. But 11 to 15 was a sweet spot, and there's a lot more research going into why is it a U-shaped curve when it comes to benefit with HIPEC for colon cancer. The other thing to know about this, here, I'm sorry, this is a slide that looks at the PCI. And you can see here for a PCI 11 to 15, HIPEC does do much better than surgery alone. The other thing about this trial that you need to understand is that the French always do it a little bit different. So they use oxaliplatin as their drug of choice for the peritoneum. And they did it for 30 minutes. And so like we typically use like different drugs like mitomycin C or oxaliplatin, but when we do it like 60 minutes or 90 minutes. So you can almost argue that 30 minutes is just too short. It's like a flash. It's not enough time for the chemo to bathe in the abdomen and kill any cancer cells left behind. So this is going to be a big topic at our annual meeting coming in March, where this is going to be debated and talked about what value this trial has on our field. But you can't ignore it, though. It does show that there's no difference, and that's the conclusion made from this trial. But maybe in subset analyses, we'll start seeing differences. So, no patients, no research, and so we do a lot of HIPECs at our institution, and we use our patients for a lot of basic science research. Our operations can be long. The average operation is about 7 hours. Sometimes they go to 10 hours, sometimes 16. It just depends on how much we have to remove. I need a lot of surgeons to do this, so I work with my GYN surgeons and my hepatobiliary surgeons to do some of these cases. But most of the time, we can do it ourselves. You need to have a good ICU afterwards. Although we've stopped using the ICU now, we've gone straight to the floor. And we've done I think we're about 120 cases right now, roughly, at our place. And so one of the things that what we've done is historically, if you looked at HIPEC patients, they're in the hospital for about a month. That's the average in the old days. And the reason why was because patients would have large amounts of fluid in their body after the surgery, and it would take a real long time for them to recover. So we started doing something the complete opposite. We do fluid restriction. So I actually restrict the amount of fluid the patients get in the operating room, which is antithetical to common thinking. And I think we're doing okay. So if you look here at the yellow, this just got published. I'm giving about 4 liters of fluid for the whole operation. So the current dogma says you're supposed to get about 8 to 10 liters. And if you look at my length of stay, it's about 7 days as opposed to, let's say, 29 days. No deaths. Our estimated blood loss is less. These are all surgical ways to help reduce. These parameters are useful for a surgeon because it helps us reduce complications, similar to how you may reduce your beam towards the heart and lungs. These are our ways to help manage post-op complications. So, and we have a decent morbidity. Our major morbidity is about 14%. So where do I think the future of HIPEC's going? I think what we're going to see here is that as chemotherapy gets better, more of our patients will actually be coming to us as candidates for HIPEC. And as these patients have persistent, stable disease, cancer is becoming a chronic problem now. It's not an acute problem. So as it becomes a chronic disease, we'll have more patients, I think, becoming candidates for it. And the challenges for us in the surgical oncology community is selecting the right patients. That's always the hardest thing in surgical oncology is not the technical operation, but the mental operation. How do you decide who to pick and what to do, and to offer this to? And so there may be some role for biomarkers in doing this. We're currently looking at KRAS status as a way to determine whether someone should be a HIPEC candidate or not. My research is primarily in immunotherapy. I have an immunotherapy background, so we're looking at ways to boost the immune system during HIPEC surgery to help get better results in mice, one day in humans. And then finally, the cost. This is the actual chemotherapy itself is very cheap, and the labor is cheap. It's only a surgeon, but the cost is more like taking care of the patients afterwards. That can be costly. This is our team that does this with our immunologists, our radiologists, our medical oncologists, and surgical oncologists that work with, and our pathologists. I should put a radonc up there. Thank you.